The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. I should point out this is the last episode of the sixth year, or the last set of episodes, the sixth year of the Virtual Curbside, and we're very thankful for the support that we've had through the years and hope that this has been as useful and as fun for you as it's been for me. It's a great privilege this month to be talking to my good friend Lisa Palmieri, who is a general pediatrician in Salt Lake City, well, in Sandy, but if you're not from Salt Lake, you don't know where that is, who has a very unique perspective on today's topic, because Lisa comes to the notion of autism squarely from the direction of primary care. She's a terrific pediatrician. And so, Lisa, why don't you give us a little background about how you ended up taking on so much more care of autistic children and neurodivergence in general?
Thank you. I'm really happy to be here and glad to have this opportunity to talk about this specific population because I'm very passionate about them. I initially went to medical school with the thought I was going to be a psychiatrist, but after a rotation in the lockdown VA unit, abandoned that for pediatrics. So when Paul Carbone offered autism identification training in the MChat training, probably 12 to 15 years ago now, I jumped at that opportunity because it was in an area that I was interested in. And it was revolutionary to sit through that conference and learn the things I didn't know about people on the spectrum. And over time, I've added to this knowledge both by collecting a significant number of patients with this and attending conferences and lectures and other training to make this a broader focus in my practice. I will say that I find myself learning new things every day and meeting patients every day that I've had in the practice for years that I suddenly now recognize have been on the spectrum. So it's a humbling area to be in. It's also humbling because I realize just how much I don't understand what goes on in other people's minds.
But also, I think you bring the open perspective that, for one thing, the only way you know that what goes on in other people's minds is by talking to them.
Right.
And by not necessarily bringing the expectation that the way you approach the world has to be exactly the same as mine.
Right.
Yeah. Well, let's dive right in. I wanted to talk this week about a group of kids where I think we think a lot about autism because, this is the sort of the roots of the problem. Okay, Lisa, before we start, do you have any conflicts to disclose?
I do not.
Okay. Well, let's dive right in. And so how is autism defined?
So this definition comes from the DSM-5, and I think a lot of people in the community, particularly the women who are impacted, find the definition limiting. So I would stay tuned in 2024 to see what comes of the movement to identify a little bit more broadly and to change some of the major and minor criteria. But that being said, the current major criteria are, number one, a difficulty with social emotional reciprocity. And I'm going to dig into that one a little more because that's the one I think that's the hardest to understand. Number two, difficulty with nonverbal communication. This includes eye contact, but also affect and gestures. Number three, difficulty forming and sustaining relationships. Those are the three major criteria. And currently, in order to have the diagnosis, all three of those must be present. And this becomes interesting, as we will talk later on in another episode, for women who tend to do fairly well in these first three criteria, but still have significant social functional issues. The minor criteria are what I think parents notice the most, and often what people who send me children for evaluation are concerned about. But you only need two of these four criteria, and these are not diagnostic. So you can have these alone without having autism. The first one is the flapping motions or stereotype motions or speech. It can be flapping, fingers near the face, spinning. It can also be echolalia or even delayed echolalia. The second one is intense interests to the point of this is what you want to talk about and this is all you want to talk about. The third one is significant rigidity, and that can be with schedules or environmental rigidity. And the fourth one is sensory issues. So this is the one that's most often brought to my attention is a child with sensory, either increased sensory needs or aversions. And parents are fairly sure that this is the reason that their child has autism. But as a believer in the diagnosis of sensory processing disorder, which is not in the DSM-5, I have noticed a lot of children can have sensory issues who do not meet the first major criteria for autism.
And yet, in some ways, our understanding of what to do about that derives, at least partly, in our treatment of kids who do meet the criteria, right?
Yeah, so you offer occupational therapy to both the child with autism and the child without.
Yeah, it's useful to have criteria because there's not something like a strep test that says this is what's going on. And so it seems like the advantage of having criteria is it does give us a foundation to build from. But as you point out, one of the disadvantages of criteria is if you don't quite fit the criteria, you may not have as easy access to some of the things that we hope are helpful.
And this has been particularly true for women who don't often meet all three of those major criteria. So, particularly social emotional reciprocity is the ability to understand how someone else in a situation might feel or does feel and respond appropriately. So many women are taught early on to have a kind of a higher social emotional IQ. And so they will respond appropriately, but do so with a significant amount more energy and or scripted behavior. So social emotional reciprocity as one of the first three criteria has made it difficult for some more highly functional social people who really need the diagnosis because they are struggling.
Yeah, interesting. Well, let's dive right in. We're going to divide this, if that's okay with you, start with some age groups, because there are some things that are particular to age groups. Let's start with the youngest kids, with toddlers and young children. And I think we've decided that 18 to 36 months is a reasonable group there. What sorts of things about 18 to 36-month-olds should make me suspicious that I should consider autism?
Anytime you have a child with significant speech delay, you would benefit from looking at autism. Luckily, the POSI and the MCHAT do that. The POSI or POSI is the test that's being used preferably right now by my organization, Intermountain Healthcare. It's a set of screening questions that is not at all diagnostic, but does point toward which child you should look at. So at 18 and 24 months, this is given to our population, and a speech delayed child with a problematic POSI should really get attention. However, if the child's speech delayed without significant scoring on the POSI, it's still worth spending a little more time in asking some more questions about this child's social development because parents are often quite aware what the POSI is asking and not ready to think about autism yet.
So once I have a suspicion, I'm going to ask questions that fill in more details. How's the diagnosis made?
Can we back up just a little? I wanted
Sure.
to add some other things. So,
Sure. Yeah.
if a child fails the POSI or the MCHAT, there are some follow-up questions that have been suggested to help the practitioner raise their level of suspicion. The first two are things you do in the room. So you have the parent call the child's name when the child is facing away, and you have the parent point at something and say, "Hey, Johnny, look," and see if Johnny can follow the point with his eyes. The next two questions are, is there a family history and is there a parental concern? So if any one of those is positive, so the child can't follow the point, can't turn to name, or there is a positive family history or parental concern, that child is recommended to be sent forward for testing. The other child that I think often gets missed is the child who's screaming through the entire exam. That's a pretty normal behavior for 18 to 24 months. So I think I would not at all say that every child who screams all the way through has autism, but it's the child whose parent is unable to comfort them in any way and can't be distracted from the high-pitched scream that does raise my interest.
And the official diagnosis is still made how?
Right now, you have two pathways in the state of Utah, and I think quite a few other states are starting to do this as well. It's always reasonable to send the child to a child psychologist who is well trained in this field and will do a thorough evaluation. However, because the lines are so long, there is a collection of pediatricians who've opted to do some training in something called the STAT and the TASI, Toddler Autism Symptom Inventory. The TASI is a history, and the STAT is a 30-minute, 20 to 30-minute toy interaction. So if you're very efficient, you can get through both of these in an hour. And these have been shown to be reliable against a psychologist evaluation for the diagnosis of autism. And in the state of Utah, Medicaid in 2024 has agreed that if both of these tests are positive, the child can get the autism diagnosis and access to the therapies.
And when you say both of these tests, you mean both of these pediatrician administered tests?
Right. So these were designed as second level screeners. They were not designed as diagnostic tests, but the diagnostic tests for toddlers are significantly longer. So this is a shortened version of the test that's really geared only to 24 to 36 months. The TASI is only for 24 to 36 months. The STAT has scoring from 18 to 48 months, but if you're using them in combination, you're really limited to 24 to 36 months.
Okay. Now, what about things that might look like autism that aren't? For instance, tell me about the role of looking for trauma.
Particularly in the younger child for whom there's been significant attachment issues. For example, child from foster care, or a child who's been highly medicalized, or a child whose early family life has been chaotic. There may be significant problems with social interaction just due to lack of stimulation or lack of trust in an adult caregiver. So if the child has a pretty significant history of trauma, that child should be evaluated by a psychologist. It's very difficult to tell the difference between early autism and early trauma. And often they coexist because perhaps the family member was struggling with mental health or autistic issues and wasn't emotionally available for the child. So it can be a pretty muddy diagnosis if there's significant trauma.
And some of the intervention may be similar, but some intervention is very different.
Correct. If the trauma is felt to be the basis, you would use something called parent-child interaction therapy, or PCIT, as most likely the basis of your therapy in order to have that child learn to trust the caregivers and the adults around them again.
What's the advantage then of making an early diagnosis? Why not just let it simmer and see how things pan out?
And here's where I don't have the data, so let me know if I need to go hunting for it. But the data has shown that the social outcomes are better for children when therapy is started between about 24 months and 5 years. The earlier, the better. So under 3 has been Dr. Carbone's goal for us. And in the discussion of getting the POSI out and in the clinic, the idea is if you have a child who screens positive, that they can rapidly go for testing. His group at the University of Utah has developed training in the STAT and TASI, and one of my partners is doing it as a routine part of her practice. So when she identifies a patient, she goes ahead and does the testing. I do it as well as a separate part of my practice, but it's available to anybody. And the email is aspire@hsc.utah.edu. And it's an out of sync learning experience that anybody can sign up for anywhere in the country and learn how to do these tests and write reports that the insurance companies will accept.
And how long does the training take?
It was a 12-month training when I did it, with 2 4-hour lecture blocks. I have not heard that it's changed from that, but mine was in person in the first cohort.
Okay. And what cost about are we looking at? Is it expensive or?
I don't remember. It's CME costs.
Okay.
So I don't know the answer to that.
That's fine. So
Right.
it can be done at CME. Well, let's talk a little bit about the intervention.
CME and MOC.
Sure. So let's talk a little bit about intervention, because there is both intervention that's particular to autism. And why don't we start with that? Tell me about ABA. What is it? And what's the advantage of starting it early?
ABA is also known as applied behavioral analysis. It is very behavioral in its training, as the name suggests, very much the Pavlovian dog training. And that's been one of its criticisms, is that it's, quote, dog training, unquote. However, it has the best outcome in terms of social skills at the end of the ABA over other methods, and it's the only one currently covered by insurance companies. So parents can look at other things like floor time. That's a parent-driven therapeutic intervention, but it's highly time-consuming for parents and requires significant parental training. But I have had a few parents that found that something they wanted to do and felt quite successful in it. ABA has a lot of negative press in the Instagram and social media world. The children who did it 10 to 15 years ago bear a lot of resentment for being, quote, trained out of their autism, unquote. They felt like the appropriate approach of the people around them was to have accepted them as who they were and not to try to change them into neurotypical people. The newest forms of ABA are much more respectful of neurodivergence and really focus on behaviors that interfere with safety or learning. So if the child wants to flap or spin and it's not hurting anyone, that's not a behavior that they target. And they don't target forced eye contact, forced allowing of touch, and other things that are very uncomfortable and even painful for someone who's autistic.
How about some of the practical things that can be helpful? Sleep can be a major issue in autism.
Sleep is probably the major issue when a parent comes to me because by the time they're talking to me, they've had almost 2 years of no sleep. Often children are up very, very early in the morning, sometimes as early as 4 for the day, sometimes up between 2 and 5 before they'll go back to sleep for a couple of hours. And parents are exhausted, particularly if there's challenging behavior during the day. Right now in this age group, the only medication that we would feel comfortable with was melatonin at very small amounts of a half milligram to 1 milligram given an hour before bed. The recommendations from the AAP are no melatonin before the age of 3. And I've seen other recommendations here in 2024 for as young as 2. Under 2, I think you would really want to talk with one of the sleep doctors.
What about GI issues?
The GI issues often stem from the child's extremely picky eating. So sometimes you'll get a child who's at 18 to 36 months who's not off the bottle and is drinking all his calories or eating only highly processed foods. So there used to be a big push for yeast cleanouts in the GI tract and balancing the microbiome. That's not nearly as prevalent in my community anymore. That was really prevalent before. Now we're mostly treating constipation and what we perceive as inadequate nutrition. And you would handle that in the same way you would with any other child who was struggling with oral eating.
You sort of alluded to this, but how do you approach sensory issues in this age group?
So your occupational therapist is your very best friend. And the nice thing about OT is sometimes you can get into it more quickly than ABA. In Utah, Primary Children's does a lot of our OT, but there are other groups privately doing it as well, including some of the ABA groups will have their own speech therapy and OT available at the same center, which is kind of a one-stop shop. And that's really nice for the family. But OT gives the parent a lot of ways to help the child from a sensory standpoint and helps them understand how that child might be experiencing the world around them. That things that feel very comfortable to the parent might be excruciating for the child. And I've seen it really open the eyes of the parent. And even in my own situation, I have a very sensory based child. And after we bought 15 pairs of shoes, it began to dawn on me that the problem wasn't the shoe. And
Yeah,
so
yeah.
we were able to make some adjustments in what expectations were for when things needed to be worn, what kinds of things needed to be worn. So it really, I think, gives the parent a lot of power and fairly quickly. And I will tell you that children love it. Even children on the spectrum love OT, and so do their parents.
It seems to me too that sometimes the whole process of arriving at a diagnosis takes time because for one thing you got a family getting to know each other. The diagnosis may be evolving, but some of these issues are there. And it seems like something like occupational therapy can be very helpful, whatever the underlying cause. And
Yes.
B, you can usually get access. To get access to ABA, you really have to have a diagnosis.
Correct. And you can go to OT if you think there are sensory issues. So I would suggest that when you are considering the autism diagnosis in the speech delayed child, sensory questions should be part of what you ask. And you want to ask not only about sensory sensitivities, you want to look for sensory interests as well as a lack of sensory response. So, for example, in the TASI, which spells out things quite nicely for you in terms of what a sensory issue might be visually, a child who's a sensory seeker visually will want to watch things spin, bright, shiny, sparkly lights, might want to look at their fingers, might want to look at the toys very close up or spin the wheels of the car. A child who is sensory avoidant will hate bright lights. And then a child who is not perceiving sensory things as well will not seem to see things he should see. So you want to ask about all three items, not just the hypersensitive kid, but the sensory seeker who's licking the furniture, or the child who doesn't seem to notice that he fell over and he's bleeding.
And as you pointed out before, our goal isn't necessarily to make everyone the same, but to allow people to do things they have to do in a more comfortable fashion.
And I think place ourselves in another person's shoes to try to see how might the world look for somebody who processes things differently. And that's what I found really exciting in the population is there's no two children with autism who are the same. And each time you meet one, you get to see the world through a set of different eyes
Yeah.
and ears and taste and
Right.
clothing.
Right. You gave a shout out to occupational therapy. I'm guessing that physical therapy, speech therapy, feeding therapy are all things that
Right.
as
And so
well.
speech therapy will often come through the school district. I think one of the things you really don't want to do here at the beginning is not refer to early intervention. So early intervention should probably be your first call before you're moving forward with your autism, because they will have access to
Sure.
speech and OT. A PT is actually, I think, missed quite frequently. A number of children on the spectrum have significant PT related issues that are not brought up, such as persistent toe walking, which can result in some Achilles tendon tightening, as well as hypotonia. One of my parents states her child kind of lays all over the furniture when he's trying to stand upright. He leans against a wall. He's never actually holding his body upright. And so PT needs to be looked at as well, but it tends to fall farther down the list. And there's just only so much therapy a toddler can take.
Right. Yeah. Who needs a genetics evaluation?
The recommendation is that every child with an autism diagnosis have a Fragile X and a microarray. We have identified a nurse in our practice who's the champion for this and a companies that we work with. And she, when we're ready to do the testing, she makes sure the kits are sent out. The companies generally are really good about helping the parents know what the costs are going to be. So you're not responsible for trying to make sure this is affordable. But that has been recommended for all children with autism. I would send a genetics referral for a child who you think has autism and congenital heart disease, autism and seizures, autism and different facies, or an unusual growth trajectory. So I would have a pretty low threshold for involving genetics if there's anything that goes with autism.
But if you're doing anything on a blanket screening level, then Fragile X and a microarray.
That's the recommendations from the AAP in
Okay.
2024.
Okay. Let's talk about the next age group up, the 4 to 6 year olds. So the early school kids. What should make me suspicious in this age group?
This age group would be the children that did not get identified earlier on, and sometimes that's simply because they have not been screened appropriately, or they had fallen out of care, or sometimes they are a little higher functioning. So, in this age group, if the parent is struggling with significant behavioral concerns, severe prolonged tantrums, aggression, significant sensory issues, communication issues, and disinterest in peers would be kind of the signal symptoms I would be looking for. A lot of times, this age group is very forgiving, so the higher functioning child may have friends. But if that child is not interested in having friends at all and doesn't try to mix with the group, that's a kid that should probably draw the pediatrician's interest. The other ones are going to show up a little bit later as social skills diverge. But the child who has no interest in what other children are doing should really catch your attention.
Are there kids in this age group who may have not met criteria on formal evaluation before, but will meet the criteria now?
Yes, particularly if the testing was done quite early at 18 to 24 months. And that child then was borderline at that point, but as time went on, did not make catch up social progress.
What's the rule for consideration of intellectual disability versus autism?
That can be really challenging. And of course, in a significant portion of the autistic population, intellectual disability is also present. So sometimes it's an and, not an or. This is why it's generally good for the psychologist to make the evaluation in this age group. The intellectual testing at the school level isn't done until the earliest at age 5 and isn't really, IQ isn't stable till age 12. So it can be very difficult to identify which child has intellectual disability only and that who has intellectual disability, the one who has intellectual disability plus autism. What I tend to use as my guideline is I remember what it's like when I walk into a neurotypical 9-month-old. I get that smile as I walk in the room, as long as I'm not too close or too loud. I get attention to the scope when I present the child with the light from the otoscope. The child looks down at the light, looks back up to me, might give me a grin or big eyes. The child might giggle when I blow on toes. So that child is generally actively trying to engage both the provider and the caregiver in the room. If the child that you're looking at doesn't have the social skills of what you would see a neurotypical 9-month-old, but has skills otherwise that are ahead of that, that child is autistic most likely. So autism is defined as social skills that are behind your cognitive skills. So even if your child is cognitively 2, then he should have the social skills of a 2-year-old.
How does intervention change at this age? How's it the same and how does it change?
It is the same. It is still ABA, OT, speech therapy, feeding therapy. Feeding therapy really does have, in my opinion, a window of success, and the feeding therapists may want to disagree with me, but when children get older, they get much harder to engage in feeding therapy. So if your child is extremely narrow in diet, the window for taking care of it really, I feel like, should be 8 and younger. After 8, it's very difficult to get them to engage in trying to do what you want them to do. So I would try to make room for feeding therapy in there. I can't tell you the number of morbidly obese teenage autistic patients I have, some of whom are pre-diabetic or early diabetic. And that is just going to be an extremely difficult thing to manage as this person becomes a young adult.
But earlier engagement with feeding therapy is like,
Earlier engagement with feeding therapy to try to prevent that morbid obesity from the overprocessed foods.
tell me about screens in this age group.
Unfortunately, screens seem to be something that really help these children neuroregulate. And with the pandemic, we introduced screens at such a rate that when you take the screen away from the child, they neurodysregulate. So I'm not sure that any of the therapy or therapists have a great way of managing this, but I know that even in my practice, I end up having to examine the child while on a screen because that's the only way they know how to neuroregulate at this point. So I think the screen has a lot of opportunity to help people, but right now it's being, I think, used primarily to try to keep an autistic child from being disruptive.
Let's say that we've identified the child, we've got them engaged in therapy. What if things are getting worse rather than better?
So this is where the complete review of systems becomes critical. And this is what we were taught in medical school for developmentally delayed patients and also in our pediatrics training. But it becomes extremely true for children on the spectrum because often they're nonverbal or they're unable to express why they're having difficulty. So this is starting at the top of the head and moving all the way down the body with every possible system that you could come up with. I have seen a number of children for whom allergies, seasonal allergies, have triggered severe aggression. So just because the diagnosis is not very more, it doesn't have a lot of morbidity, doesn't mean it's not causing a lot of behavioral morbidity. So I had one young boy who came in to see me with a sudden increase in his aggression against himself, and he was physically digging his eyes with his fingers. So we were, really concerned about the safety of his corneas with the level of aggression he had on his face, and it was his hay fever.
And so, in essence, kind of an amplification of symptoms or a modification of symptoms, but by the neurodivergence.
And I ought to throw out a somewhat controversial idea here as well. I think this population is particularly prone to panda-like responses to illness. So panda is I can't remember the term, Paul, here, pediatric autoimmune. PANS, probably not panda, but these children are exquisitely sensitive to interferon. And so when they get a minor illness or even a cold coming on, behavior will often worsen 24 to 48 hours before symptoms appear. And so letting parents know that that can happen is very helpful. I haven't checked many of them for strep. I have some that have gone to the full PANDAS treatment, but I haven't felt that that made a huge difference in their outcomes. But I do believe that interferon and illness are significant predictors for worsening. The other one that tends to get missed is seizures. They have a much higher rate of seizures, children in this population, and they often occur during sleep in the kids with epilepsy. So you want to look for changes in how hard it is to wake the child, how tired they are in the day, how restless they are in bed, how much drool is on the pillow, or any other minor neurological changes during the day, maybe a little more unbalanced when they get up in the morning, a little more unsteady. Those children will have very disrupted sleep if they're seizing in the night, and then they become much more difficult to manage during the day. So your friendly sleep provider who runs an EEG and a sleep study together, if the child can tolerate it, can be very helpful in this setting.
And extended from that, one of the advantages that you have at this point is the child has more points of contact. And so ideally, we can get information from the family as well as from therapists, as well as from the school. And we have somebody seeing the kid in a lot of dimensions now.
And I would encourage providers to talk to the preschool.
Yeah.
We will talk to the kindergarten or the first grade, but we don't often talk to the preschool. Preschool teachers have seen lots of kids. I had one child that we were examining for autism who came from a different culture, which made it more difficult to try to understand. And the preschool teacher said, I don't see it. He's well liked here. He's friendly with all the other children. So I sent him on for psychology testing because I think he probably just has intellectual delay. But he's very significantly delayed intellectually, but not as much socially, particularly according to how the preschool teacher sees him interacting.
Interesting. Well, anything else you want to say about this age group?
Yes, I think there's two
Covered a
things
lot of
that I
ground.
wanted to hit quickly. And one is that when the psychologist makes the diagnosis in the 4 to 6 age group, we're not one and done. So that child needs to be retested about every 3 to 4 years. That testing doesn't change the diagnosis. So I really would encourage providers not to say the child will outgrow autism or learn from the therapies not to be autistic. That's not what most parents are even wanting now. They're much more accepting of a neurodivergent diagnosis and will often come to me saying, I just want my child to be happy. I don't care what they like or how they behave with their flapping. I just want them to feel content. The reason you retest is to re-identify where needs are. And also for some state programs, you need a test that's more recent. You can't rely on the child's test at age 4 for some funding when he's 15 to 20.
Sure.
The other thing I would say is it's been to my shame, the number of children that are moving into the young adult years in my practice that I've known have autism, but it's been an educational diagnosis and not a medical one. So the child right now in the US needs both diagnoses, and that just is double hard for parents and really needs to be changed. But you can have the identical testing done at the school, and it will not be accepted for state funding unless a psychologist outside the school system does it as well, or an MD. So
it's something that I was getting access sometimes. I think people get very discouraged with the very long waits.
Oh yeah, so they don't need anything more because they're getting everything they need from the school. But when that child ages out of the school system and needs the additional resources and doesn't have the medical diagnosis, the state won't pay for it.
Well, I think this has been very helpful, Lisa. I feel both, more encouraged and a little smarter and also a little overwhelmed. So I'll digest this a little bit. You want to put in another pitch for the training program at?
Yes. So this again is a very exciting training program, and even if you find yourself not wanting to devote the time to testing, knowing what you're looking for is really good. And so this is the Aspire program through the University Developmental Assessment Clinic at the University of Utah, and it's at Aspire at hsc.utah.edu, and you can send them an email and they will tell you how to sign up. The training gets you both CME and MOC credit, and I think it really broadens your ability to start to recognize social patterns.
And since it's asynchronous, guessing that you can start just about.
You can start anytime. Yep.
Well, thanks so much, Lisa. This has been very helpful. I'm very excited to talk to you again next week about the older age groups. For those of you who have questions, and I know you do, send your questions to questions@vcurb.com, and we'll address those in a couple of weeks. Dr. Palmieri, thanks for your time. We'll talk to you next week.
Thank you very much. Thanks for the opportunity.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Paul Wirkus, who also composed the theme music. See you next time.